everyone. Welcome to LDI's seminar on Big Business in Healthcare, Policy Challenges in the Age of Corporatized Medicine. I am Rachel Warner. I am the Executive Director of Penn's Leonard Davis Institute of Health Economics. I am looking forward to our conversation today with our panelists. So profit motives have long been embedded in the US healthcare system, but it often feels now like we're entering a new era of big business in healthcare. We have increasing private investment in healthcare, a growing role of private sector actors, and corporations leveraging market power through things like mergers and acquisitions to maximize profit. On one hand, some of these investments may improve the efficiency and the profitability of healthcare institutions. Yet research suggests that while investors benefit, patients often do not. In response, federal and state regulators are making efforts to scrutinize deal-making, pass legislation, and regulatory measures, all aimed at putting patients' interests first. Today, we will examine the big business of healthcare, why it is happening, the evidence around its effects, both positive and negative, and possible approaches to protect patients against its ill effects. We have a great group of panelists joining us today, and I want to go ahead and introduce them. First, Erin Fusay-Brown is a professor of health services, policy, and practice at the Brown University School of Public Health. She also serves as a consultant to the National Academy of State Health Policy, aiding in the drafting of model state legislation to address the corporatization of healthcare. David Cutler is the Otto Eckstein Professor of Applied Economics at Harvard University. He served on the Council of Economic Advisors and the National Economic Council, and he is currently a member of the Massachusetts Health Policy Commission to help reduce medical spending in Massachusetts. Kwame Raoul is the State Attorney General of Illinois. He has publicly advocated for increased oversight of private equity in healthcare transactions and practices, and has worked to lay out possible enforcement and regulatory actions to address its detrimental effects. So thank you all for joining us today. I wanted to jump in and get started, and we talked previously and we agreed we're going to use first names. So Erin, I'm going to start with you. If you could just provide us with a little bit of background information and maybe some definitions. What do we mean when we talk about the corporatization of medicine, of healthcare?
Hi, thanks, Rachel, and thanks for inviting me to participate in this great discussion today. So yeah, corporatization is one of those terms that is sort of capacious, and I think it's useful to define it. One of the best definitions or conceptions of the term corporatization actually came from Paul Starr's iconic work, The Social Transformation of American Healthcare or American Medicine, over 40 years ago. And that book, the second part of that book, really predicted the rise of corporatization or the corporate transformation of healthcare. And the way Starr conceptualized it was to really say that, corporations are going to come to dominate the healthcare system, both in terms of its political power, its organizational power, its economic power, and the corporations that are controlling the healthcare system will increasingly be large conglomerates. In other words, not small, community hospitals, but large, national or regionally powerful and dominant firms, increasingly, integrated across multiple platforms in the healthcare economy. So drawing on this conception, I think a good useful definition for corporatization refers to this general trend that we've seen throughout the healthcare industry toward much higher levels of integrated control by consolidated profit-seeking enterprises. So this is like, that is my working definition of corporatization. And I want to highlight two concepts that are embedded in that. And first is the profit-seeking part of it. You talked in the introduction about the elevation of the profit motive. And I think that is central to the concept of corporatization, is that, this famous sort of neoliberal idea of shareholder primacy says profits, securing profits and generating wealth for shareholders and investors is the primary duty of a corporation. And there have been lots of contestation of whether that's in fact, normatively true, but that concept also then means that the other stakeholders, including patients, the community, the workers, are all secondary, meaning their interests are far subordinated below the profit-seeking enterprise's profit motive. So I think that's one of the fundamental elements is profit seeking. The other element in Starr's original conception is size, is this consolidation to the scale and scope where you see, again, it's not the small regional or local health system, any hospital anymore. It's large, sprawling health systems. It's vertically consolidated entities. Examples of corporatization, include like the many hospital systems that own 50 plus hospitals in their chain that span multiple states, or the United Healthcare that owns everything from insurance companies to physicians to home health to PBMs to pharmacies to change healthcare. So that is, I think, the concept of corporatization that Starr was describing. And I think the one thing I just wanted to mention is that there are often uses of the term, other terms that I think are similar, frankly, because they get at this profit notion. And it is like things like financialization has been used. Financialization is very similar in my mind to corporatization, but it emphasizes the entry of financial firms like private equity that use extractive tactics to not only invest in healthcare, but to mine it in a short-term basis for profit for those investors and then quickly get out. So that would be, I think, a similar concept to what we're talking about today.
Great. That's helpful. Thank you. And so I want to invite David and Kwame to just jump in at any point. I think you've provided some examples, but maybe just a couple specific examples of what we've seen in the past, few years of that represent the corporatization in healthcare would be helpful.
Yeah, so I think, one of the prime examples would be the Steward healthcare collapse. Everyone, David's nodding his head because he was on the front row of seeing that catastrophe unfold. But private equity backed Cerberus Capital invested in and took over a nonprofit Catholic health system, originally, multiple hospitals in Massachusetts, turned it not only for profit, but also then used sort of like what we now know as the classic private equity playbook to, strip the assets, buy more hospitals, expand the reach of the Steward footprint, and then get out. So, the private equity firm exited the investment, but left this hospital chain in an increasingly dire financial situation so that we have the collapse of the Steward, the bankruptcy of the Steward, health system and hospitals across the country, leaving, ruins for state policymakers and state communities and local communities to deal with. So I think that is in some ways sort of the iconic case of a corporatization in the healthcare system that we've seen recently. But as I mentioned before, United Healthcare is another example, and we saw the spasm of anger and outrage that followed the murder of the CEO of the insurance arm of United Healthcare. And that, I think, is in some respects reflecting this idea that I think the public is starting to wake up to the idea that the healthcare system is increasingly dominated by corporations that do not put patient care first. It's not only that they don't put it first, it's like not even in the top 5 things that United is concerned about. And so it's the scale, you can't avoid it. It's so big, but also it is increasingly seen as putting profits above patients.
Thanks, Aaron. That's helpful. David, I wanted to turn to you. Aaron brought up the Steward Healthcare example, and you've talked a lot about profiteering in healthcare as a need to balance patients and profits. The Steward Healthcare example is one of those that you've talked about. Maybe you could just tell us a little bit more about your thoughts about Steward and also whether or not corporate involvement really always comes at the expense of high quality healthcare.
So thank you, Rachel. Thank you for organizing this and for everything that you do. You all collectively do at Wharton, which I think is just spectacular. The front lines of the Steward disaster are every bit as bad as they look from the headlines. Hospitals going out of business and patients with nowhere to go and staff with nothing to do, and just terrible, terrible situations, hugely adverse situations for the Commonwealth. I want to come back to the point that you made, which is sort of what's new or different, or how to think about this. So stepping away from Steward for a second, but I understand one can only do that for a second. I as an economist, have actually mixed views about corporatization. So let me give you why. On the one hand, you have these sort of call it the vulture capital version of corporatization, which is, I'll leave out proper names, but I want to take the assets, sell the assets. One of the companies involved in Steward kind of, sort of indicates in its various annual reports that it likes to invest in distressed hospitals because if they don't do well, you can always go to the state and tell the state they have to put up more money. So it's sort of like an explicit strategy of theirs to say, well, we're going to extract money from the states. And we've seen that, I think, in Pennsylvania. You had a situation of a hospital that said, you either give us, I can't remember what it was, $70 million right away, or we close the hospital right away. And then the state gave some money and it closed the hospital 2 years later. So there's sort of that version. There's the other version, though, which is that there's a lot of good stuff that you need somewhat deep pockets to do. And so there's the sort of old phrase, which is doing well by doing good. There's enormous opportunity for that in healthcare. I'll just give you two examples that I keep in my mind. One is improved primary care. So better new non-traditional models for running primary care. We've seen a lot of those, from the Iora Healths to the Chen Meds to the Aledades and so on. Those are all venture capital funded. Those are all, the distinction between what's venture capital and what's private equity is not a clear distinction. Those, if we said, well, no venture capital investing, we would cut that out. And that would be a real shame because those are really working well for a lot of people. Another example where I think healthcare could really benefit from more would be, say, the hospital at home movement, where many people are in a hospital. They don't need to be. They can be monitored at home, especially if they have a relative, and certainly if you've got good monitoring technology. But no healthcare organization is in any position to do that. Like, the sort of hospital at home programs are more or less anemic around the country, even though in other countries they tend to be somewhat bigger. And where, the example that I keep in my mind is one health system that's working with Best Buy. And why are they working with Best Buy? Because Best Buy actually knows how to install the equipment in someone's house. So like if you need to do a hospital at home, you need equipment in someone's house. How are you going to do that? You get the Geek Squad guy to go out and to install the equipment in someone's house. And so those are examples of things that I think are good. So the issue is what corporations are really good at is they're really good at responding to incentives. And if those incentives are good, then you can get great things. And if those incentives are terrible, then it's really awful. And so to me, that's what I think about is less, do we want responsive corporations? Do we not want responsive corporations? But how can we get the incentives right so that when we do have folks that respond very strongly to incentives, what they're doing are the things we want them to do, and not the things that would harm patients, harm communities, harm workers, and so on. And so I think it's a very tricky situation. And it's also one where the balancing is going to be hard because mistakes can happen quickly and have repercussions quickly, and the successes will often take a while to be realized.
And so if I could summarize what you're saying, part of it is that we need private investment to innovate within healthcare. Healthcare delivery system is certainly not perfect, and there's room for improvement. And that investment can help us improve through hospital at home, through innovative primary care models and things like that. How do you think about, so those are much different examples than Steward Healthcare, obviously, where there was really private equity backed investment for the sake of profit only. So how do you think about balancing those incentives, or how do you think about getting it right?
It's very hard because, we've seen things like Steward before, like an earlier version of Steward, but that turned out to be very successful, was HCA, right? And HCA was like, we will be basically the Holiday Inn of healthcare. So we're not going to be, the Four Seasons of healthcare, but we're not going to be the Fleabag Motel of healthcare either. We're going to be, at a good level and be affordable. And actually, when Steward bought up the Catholic healthcare system, they were not doing very well. They were not well managed and so on. And so people had a lot of hope that Steward could run them better and they could be the sort of equivalent, something like the Holiday Inn of healthcare here, like a very, very good but not super special, fancy teaching academic kind of place. And I think for a number of years, that's certainly what they tried. I mean, who knows what happened? You know, there are several books I'm sure that will be written on the transition from that to the other one, to the other version of Steward. But it's sort of, I think partly it's sort of what I want to do is think about some set of regulations. It seems to be coming back to your earlier point. One of the differences is you can strip assets much quicker than you can build successful businesses. So therefore, one of the things I want to do is keep folks from taking money out soon. So I want to say, well, you have to have your money in 5 or 10 years. And you can't take it out. Now, unfortunately, that would not have prevented Steward because it was actually quite a long time between when the money first went in and when the money came out. But that could prevent other kinds of things. So I want to kind of fix the financial incentives and the regulation to try and limit those things, even though I don't feel like I either can or want to just say no to everything.
Okay. Kwame, I want to pull you into this conversation. David started sort of talking about potential solutions or ways to think about making this work better. I know you have thought a lot about solutions, and you've been involved in both the implementation of legislation in Illinois to improve oversight of these kinds of transactions. You were also part of a multi-state coalition of attorneys general who recommended additional federal enforcement and regulatory actions. Can you tell us a little bit about the approach, about the elements that were in Illinois' approach to try and address some of the misaligned incentives that have caused corporatization to result in poor patient care?
Yes, certainly. And again, thank you for having me today. First off, I want to say that I come to this as the child of a physician, the sibling of a physician, and the husband of a physician. And through the perspective of each element of that being, I've seen my father retire from the practice of medicine early, and this is some almost 40 years ago, because of what he saw or perhaps foresaw in terms of the corporatization of medicine, even in the late 80s. I've watched my sister, who is a physical medicine rehab doc, have her load change to where she doesn't feel like she's adequately given patient care. And I've had my wife leave a medical practice after a couple of acquisitions for the same sort of reason. So between those anecdotal experiences and complaints that come to the Attorney General's office to do something about acquisitions that have changed the nature of care after the fact, I went to the legislature a couple of years ago and said, the best way for us to respond to this is beforehand. And we requested an amendment to our Illinois Antitrust Act that would allow us to have notice at least 30 days before the closing of a transaction, either proposed merger, acquisition, or contracting affiliation. Prior to this, we were not so informed, and then we were asked to respond to negative outcomes after an acquisition, whether it's closing down of a facility, reduction of access to care, higher nurse to patient ratio, things of that nature. And so this requirement can be satisfied in several ways. One, we have a health facilities service planning board. And so we have, since the implementation of the act, we've had 38 proposed transactions, and 27 were reported through that Illinois Health Facilities and Service Review Board. 10 were using a health care transaction notice form, and one reported via the Federal Hart-Scott Rodino formed, which is also submitted to FTC and DOJ. This allows us an opportunity to peer into the potential impact of a transaction before it takes place, to ask questions, to get commitments, which we would not be able to get after the fact. And so, while 30 days is not an eternity of time to peer into a transaction, it at least allows us an opportunity to evaluate it and investigate and decide whether we take action to stall or to prohibit the transaction.
Great, thanks. And maybe I'll ask Aaron, I know that you've worked on model legislation with NASHB. Then what does that look like? Tell us a little bit about what those elements look like.
Yeah, so I think a lot of the elements of the NASHB model, which is designed to address sort of consolidation and corporatization in healthcare, involves exactly the type of oversight that Kwame just mentioned, and that also Massachusetts pioneered, which is to get prior notice of a material change transaction in the healthcare, across the healthcare spectrum. So that is, not just big mergers and acquisitions, although you certainly want to see those, but also the smaller, physician practice acquisitions, clinic acquisitions, affiliation agreements. Those are the types of transactions where you might see, again, private equity or other types of corporate actors rolling up physician practices and consolidating the market. So that's the one piece, is sort of prior notice, but also the authority to review, and to review under not simply to review under antitrust standards, but to review under sort of a public interest standard, to look at the impact on the workforce, on equity, on patient care, on access, which often, is the primary concern, is not so much that it's increasing the market power of any one entity, but it could threaten access or patient care quality in some other way. So that's one. And then I think part of the NASHB model would go even a step further, which some states have done, which is to allow either the sort of healthcare oversight agency or the attorney general, or both, actually impose those conditions and block the transaction if there are enough concerns, without having to seek a court order, which doesn't necessarily, it sounds like sort of a legal technicality, but it actually it changes the dynamic of that oversight, because it means that the attorney general's office doesn't have to pick and choose the big fish, the big ones to have to go to court about. And so that there's some additional oversight, there's additional, conditions that can be placed. I think what Kwame pointed out is very important. The second element is ownership transparency. So a lot of this is happening without necessarily, particularly among the physician practices and the smaller clinics, there's not a lot of national data on, someone says, well, what happens when, such and such player, how much is it here? How much is private equity rolling up our physician practices? Or how much is, who are the 90,000 physicians that Optum owns or affiliates with? And there are no national data sets that can actually point you in that direction. So some states, including Massachusetts, are really pioneering that approach of requiring the sort of comprehensive ownership and control information, so that the state overseers and patients and communities can know who owns my doctor's office. Where is this corporate chain leading? Who's the ultimate parent? And then the third piece is to strengthen the corporate practice of medicine doctrine, which is really to think about how, in particular, these corporate transactions affect the physicians and the clinicians who are licensed to practice and are supposed to be able to exercise independent clinical judgment. But what we're increasingly hearing and seeing is that these corporate management service organizations or affiliations really take over the practice and start to interfere with or put financial incentives or huge pressure on the clinicians in the practice. So the strengthening the corporate practice of medicine doctrine would create more space so that those management service entities can still provide administrative services, but there are certain key decisions that they cannot interfere with.
Mm-hmm. Okay, thanks. So that's helpful. Thank you. Actually, I want to ask a specific question. And Kwame, this may be directed more at you, but Aaron, you can chime in, or David, you can chime in also. There's actually a question in the chat about what red flags. So, prior review of mergers and acquisitions is one of the things Kwame talked about, and Aaron as well. And the question is, what red flags do you look for? What types of things make you concerned? And then what do you do? What kind of commitments are you seeking?
Yeah, certainly. First off, as Aaron alluded to, is the who. Um, so who's acquiring the facility or the practice, and what is their track record, right? That will speak to what we can expect. Normally it's an out of state actor that's been active elsewhere, and we can look at that track record, but we have to look at it specifically to our healthcare ecosystem, such that the impact isn't such that we're creating healthcare deserts as a result of a healthcare transaction. So, looking at that track record, applying it to what our ecosystem looks like, and trying to extract commitments such that it does not have a negative impact on access to care in certain regions of our state or our cities. What is the commitment to staff, such that we don't see the reduction in staff that, again, while they may maintain the facility, if the staff reduction is such that access to care is reduced as a result, that is something we query into. Whether when they're acquiring a facility, will they maintain all the services the facility previously offered? So they may maintain the facility, but if there's certain specialties and certain access to services that have been historically relied upon at that facility that no longer exists, those are the things we would query into.
That's helpful. Thank you.
Rachel, if I can jump in on that. So we have a prior notification procedure, as Aaron was saying, in Massachusetts. And the Health Policy Commission, which I'm one of the commissioners of, sort of does those. And it's very explicitly not just an antitrust review. That is, it's not just that, but whenever there's a consolidation of any form, as well as a number of other things, the providers have to provide notice to us, and they're not allowed to close it until 30 days after we've done a review. We can choose not to do a full review. We can choose to do a full review. If so, we can't block it. Like, we don't have regulatory authority to block it, but we write a report that indicates what impact we think it will have on the citizens of Massachusetts in terms of cost of medical care, quality of medical care, so on. And then we sort of think of the reader of the report as being the Attorney General of Massachusetts, because the Attorney General can then choose to go to court, can choose to say that they believe it's not in the public interest and possibly go to court over that. And there are many statutes under which that can happen, from antitrust statutes to things like community, standards about, community healthcare needs statutes and what's best for the people. So it does provide a way into this, but fundamentally, so it's great, and we've had a lot of success with it, but it is very, very difficult, just to come back to it, because sometimes what happens is people come in and they say, look, this hospital is about to fail. We've sort of looked around, and the only people we can possibly sell it to is X. And if you say no, X will walk away, and we've just got to shut the thing next week. And so, like, you think, oh, okay, we've got this great process and so on and so forth. But the reality is, like, sometimes people just say, I'm sorry, on Monday, the thing is not operating. It's now Friday. What would you like to do? And that's just a horror. And, you can say you have to, we have this, have to provide 30 days and stuff. But, like, when they say we can't make payroll on Monday, then what do you do?
What do you do? Go ahead, Erin.
Well, and I think that I'm not sure if I know what you do in that situation, but I think that that's the difficulty of, like, even if you identify those red flags, like, as Kwame said, like if you've seen that this particular buyer has not the best track record of maintaining quality or services or access, but really is sort of a tends to sort of strip away assets. So there are some that's where the conditions or the conditions to the transaction come in, that negotiation of like, okay, you want this transaction to go through, you're not going to sell the real estate to a real estate investment trust. You're not going to, slash the workforce. You're going to maintain key service lines like maternity, labor and delivery services that are typically more Medicaid paid and therefore less profitable than other types of services, but the community absolutely needs them. There are certain, specific conditions that can be extracted in addition to you're not going to raise commercial prices in this way. But there are lots and lots of it sort of is required because you're right. As David said, the parties always come to the oversight, even in states like Illinois and Massachusetts, where there's robust oversight and review process. The parties come and paint the best, both the most dire picture of like why you need to approve this transaction because this is a failing firm and the hospital is going to go away if we can't merge by it. But then they also promise that like, oh, we're going to do all these great things. All this integration is going to create improved access, improved quality, improved efficiency, improved equity. And then, of course, it's a matter of negotiating conditions to make sure they actually make good on those promises, because we know from the literature that merging, particularly hospitals, but it's sort of across the board, that once a merger occurs, that there is really no incentive to make those investments, but rather, the behavior of the large entity is corporatized, right? It puts profits first, and so it looks at their array of hospitals as sort of balance sheet items, and so it's like, this one's less profitable. Let's close Hahnemann Hospital, right? Let's close the hospital that is the least profitable, the Atlanta Medical Center, in Atlanta. And so it's like, it's not enough to just be able to say, well, we got, it's yes or no, but it's about being able to provide robust oversight in the long term, and negotiate really stringent conditions if those transactions are allowed to go through.
Do any of you have any sense of how effective these approaches are? Do we have enough experience to know whether or not, like the work, Kwame, that you've done in Illinois or David in Massachusetts, are they going to be able to make a difference?
Well, I think so. I mean, I'm trying to avoid. I won't name any particular facilities or entities, but I think in the short term, we've been able to query into an acquisition, and there's been a lot more outreach in terms of how they would make commitments and in ways that may not have occurred, but for the requirement. Certainly, if you don't have to do something, then and your ultimate goal is profit, then you minimize what types of investments you need to make. If you have to satisfy a regulator ahead of time, then you make commitments that can be monitored even after the fact. We have different tools. We have the antitrust tool ahead of time, but we also in my office I have a Consumer Fraud and Deceptive Practices Act that we've used in all sectors, including the healthcare sector.
So we try and pay attention to, and we try and do some looking at what is the impact of things we've done. And we think we have been generally effective, but generally effective we do some things. I think I put this in the category of things that are like being the policeman, if you will. This is like someone wants to do something bad and your job is to stop them from doing something bad. Or if you think it's bad, they may think it's good, but if you think it's bad. And so that's a measure of effectiveness, and we think we've done reasonably well at that. You need to couple that with a strategy of encouraging more of the good stuff and not just regulatory, through the kind of payment policies and through the other forms of formal and informal support that that organizations and people get from the state and so on. And our view is that we've been moderately successful at that, but not as successful as we would like to have been. So, just to take an example, the payment system in Massachusetts, as in everywhere, penalizes hospitals that care for a lot of low-income patients. And so those are naturally the ones that are going to get in trouble. And then if you take them over, they're going to go under and stuff like that. Like a good thing to do would be to have a payment system that doesn't do that as much, that doesn't penalize institutions that take care of poor people and stop, if money shows what you care about and you actually care about everyone, then you should pay well for everyone. And we haven't had as much success in doing that. So we still have these sort of structural problems. And it's fine to be a pretty good policeman, but it's much better to not need the police.
Touche. Okay, question actually from Mark Pauly, who some of you may know. Mark points out that 25 years ago, there was millions poured into buying physician practices, and investors lost money, and that much of what's happening now with private equity acquisition is quite similar in some ways. And the question is, won't this financialization fizzle as investors move on to more profitable opportunities? Is there anything different this time? And this actually echoes what I've heard from people in the business of private equity, which is they've sort of, they're going to reach a point where they suck the financial opportunities dry and then move on. Any comments on that?
Well,
Everybody unmiked all at the same time. Go ahead, Kwame.
again, I'll combine a little with trends. I played basketball, and that probably makes me more likely to be a patient at one of these facilities. But I've got a buddy who just approached me on the basketball court and said that his son's dentist was out of town, and he took his son to a private equity-owned dentist operation chain, and his wife reported back that his son had some 15 cavities that needed to be operated to have attended to. His dentist gets back in town and he had no cavities. So what's happening is shifting the profit incentive has it such that you'll have providers suggest costlier or unnecessary procedures as a means to make it a profitable entity. And I learned thereafter that there was an article about just a trend of this throughout the country, which I was ignorant of. And it's not limited to dentistry. It's seen in other specialty areas where, on the one hand, you may have insurance companies trying to reduce referral for necessary costly procedures. On the other hand, you have providers that are corporatized, recommending people to costlier, unnecessary procedures.
And if I may jump in, I think that's a great illustration of sort of what is how this shows up, in the individual family's pocketbook or their experience. And I also think that, yes, that we had this experience before with the PPMCs, were acquired and invested in, and then sort of there was this like massive Ponzi scheme and they sort of fell apart. And then, they were sort of divested and then In some ways, I don't think it just totally went back to the status quo. And the reason I think this time might be different, or maybe not totally different, but there's still reason to be concerned, is that when, let's say, private equity comes into a specialty physician market, buys up a bunch of practices. Yes, they're not there for the long term, but they usually, when they sell to other secondary private equity, or they'll sell to, a large buyer, like all roads lead to Optum, like a payer or another type of corporate buyer. And at that point, the valuation of the sort of sale, the secondary sale price, bakes in all of the financial engineering or the profit revenue generation strategy that the private equity firm put in place to begin with. And that might include cutting staffing, increasing those, unnecessary services or upcoding or whatever the strategy is. That is, again, has to be carried on regardless of who subsequently owns that practice in order for that practice to be sold to the next buyer. And so the practice is sort of fundamentally changed. And again, the decision-making authority and the judgment is ultimately just sort of taken out of the, it's no longer sort of like a group of physicians or dentists owning their own practice and making their own call. Now they're just sort of subject to their next corporate boss telling them, this is what we need to do to hit our targets this month. So I think that even if this doesn't work out and if things fizzle or PE, moves on to greener pastures, I think it still will fundamentally change the way healthcare is practiced, and the subsequent buyer, it's not going back to like the pre-days where we have lots of fragmented independent providers. I think we're going to be in a world of other corporate buyers are the ones who are going to carry it on, and if anything, double down on some of these strategies.
That's interesting.
I thought I would tell Kwame actually in another bad part of his story, but then talk a little bit about going to Mark's question. So the other bad part is that in addition to private equity owning it and pushing them to do more, procedures and stuff because procedures pay well, it turns out in many communities there aren't all that many dentists. And so you can buy up and own a large share of the dentists in not that much time, or anesthesiologists or whatever. And you can achieve close to a local monopoly. And then you go to the payer and you just raise prices, and there's not very much opportunity for people to respond to that. So the price part is probably as big, if not bigger, than the quantity part. I mean, there've always been unscrupulous dentists who would do root canals as if, they were going to, lead to happiness for the patient. I think some of what has made the world different now, maybe for ill and maybe in some cases for better, is the huge role that information technology can play. And so if you say, what is the antidote, if you will, to some of that? You could have actually, and I know companies that do this, you could have, it turns out, teledentistry. You say, how on earth do you have teledentistry? The answer is you have a dental hygienist do the cleaning and take the pictures and upload the pictures, which are then read by someone in wherever, in Georgia. And the person in Georgia is not going to be doing the filling of the cavity. So the person in Georgia can just read it and say, this person does or doesn't need a cavity, and then filling, and then you can deal with it from there. So on the one hand, the information technology can help democratize things because, information can move around and you don't need the local care providers, whether they're good or bad or so on. On the other hand, the IT needs sort of are one of the reasons why providers want to get into these bigger systems, because they don't want to handle the IT stuff and they don't want to be responsible for updating their EMR, and they don't want to deal with all the admin stuff and so on. So it's sort of, if you will, a race between those. Like if we can use the technology to expand access and to lower the costs of practicing and being independent and so on, then that would be great. And if we're going to use technology to basically figure out, if I buy these 3 docs, I can raise the price of anesthesia by 27% and pay them 15% more, so I've got 12% profit left in and so on, then that's going to be really harmful. So again, I keep coming back to, the same things that make your life hard can also make your life be better depending on how you use them.
Great. let's see. We've talked about some of the effects of corporatization or profiteering in healthcare related to innovation and related to poor patient outcomes. I wanted to address two other points, and David, you actually just sort of referred to one, which was what do we know about the effects on access to care? And the other question is, how does the workforce play into this? And what are the relationship between corporatization and workforce? Does anybody want to take one of those to start?
I'm happy to talk a little bit, particularly about the workforce issues, and then, certainly the access questions as well. So I think that there's been some great research recently that's starting to emerge, including by my colleague Yashaswini Singh at Brown, who's really been studying sort of what is the impact of private equity investment on workforce, particularly physician turnover. And physician turnover is not necessarily in and of itself like a good or a bad thing. But what we can observe sort of, again, qualitatively is that beneath sort of high levels of physician turnover, you might see sort of a disruption of the physician-patient relationship. But there's also a sense of like maybe there's some dissatisfaction there that's like causing a lot of churn within a practice once private equity invests in it, or we know that physician practices that are private equity owned have greater, turnover at the physician level and greater substitution by advanced practice providers. Again, not necessarily itself a good or bad thing, but it just sort of paints a picture of a different way of practicing. It's obviously, if you can substitute with cheaper types of providers, then that could be a good thing for patient care and for patient access, but it also could be a bad thing if the same number of providers or a smaller number of providers are seeing a greater number of patients or a higher volume of services. They may just be, their time and their care for that patient, each individual patient goes down. So I think there is certainly concern that the cost-cutting measures, the way to cut costs in healthcare is to cut staff, and that seems to be, we see that show up in quality drops in facilities, in particular, hospitals and nursing homes experience dramatic quality losses when due to the staffing cuts that private equity puts in place when they take over. So I think that's sort of this emerging picture of like it's complicated, but we do see that there is an effect, and it tends to increase turnover, exit, churn, and replacement.
Things. Anyone want to comment on access specifically? I mean, I think one of the arguments I often hear about the importance of investment from either VC or private equity in hospitals or even mergers is that if it were not for that, they would close. Comments?
We get the failing firm defense a lot. And it's always hard to know what to make of it. And sometimes sometimes that winds up driving it. On occasion, we've still said, no, don't find a different buyer or something like that. Or, there's sometimes other folks, hospitals failing, we need to merge with the big hospital in town, the big academic medical center in town. Well, no, why do you have to merge there? What isn't there some other thing that we can think about? And the more time you have, the more ability you have to deal with that. One thing that we're trying to do now in Massachusetts related to that, by the way, is a little bit of health planning. Not like health planning, like, as a return to certificate of need, extensive certificate of need, but just like, how many hospital beds do we think we'll need in Boston 5 years from now? And therefore, or 10, 15 years from now. So therefore, do we expect that we'll need to see some downsizing of institutions because of that? Or, just so like a little bit of understanding about where things are going so that we can at least be prepared to act a little bit sooner and with some more knowledge about how to structure things. I think in general, thinking about what's most essential and therefore if something is so essential that you're, too big to fail, then you'd better be regulating it a lot because you don't want someone else making that decision for you on what to do with the too big to fail part of it. And that's not directly on the worker side, but that it has implications for how one thinks about the worker part of this.
We've talked a little bit about incentives and the way that incentives in healthcare are, especially in the for-profit part of healthcare, structured in a way that encourages this kind of corporatization. And yet we also see this kind of behavior in the nonprofit, the not-for-profit side of healthcare. I would like to ask you all if you could just comment on why we're seeing this happen in nonprofit healthcare as well. And David, oh, Kwame, great, go ahead.
Well, whether for profit, whether the structure is for profit or not for profit, they still have to make ends meet, right? And they still have to operate a system. Still our major systems here in Illinois are not for profit systems that largely operate as if they were a for profit business, and we do have charity care requirements and so forth to sort of help regulate and leverage to make certain that we maintain healthcare in the public interest. Notwithstanding that, necessarily for survival's sake, they've got to treat it as a business. And how to navigate that. David spoke to earlier the use of hygienist in dentistry. We've seen legislatively, policy-wise, a great debate in a whole lot of different practice areas, whether it's optometrists and ophthalmologists, nurses, anesthetists, and anesthesiologists. There, I mentioned that because my wife is an anesthesiologist. But across the board, efforts to minimize costs by removing responsibility physicians. Meanwhile, physicians still have to pay exorbitant tuition costs to go to medical school, and how do you balance all that in the scheme of operating a business, whether for profit or not for profit?
Great.
And I would just chime in. I think that all of that is true, that it's a very complicated question, because on the one hand, we do know, and we've observed both in the evidence, but also just in the news, that nonprofit hospital systems and nonprofit institutions can behave more or less identically to a for-profit, profit-seeking enterprise, even though they are organized as a nonprofit, have a charitable mission. And I think part of that is to do with size, particularly once a nonprofit system gets to be so big that it's not really accountable to the local community anymore. That it's sort of a central, sort of distant, removed, centralized decision-making function. It almost sort of like loses that community accountability and that sort of community benefit mission and to its organizing principle. So I think that there's something about size that makes nonprofits behave more like for-profits, but also at the same time, that's not necessarily a reason from a policy standpoint to throw out the nonprofit form and say all these nonprofit systems should be just taxable, and we should get rid of this lever that they very much care about, which is their tax exemption. So I think that maybe it's to look instead at like making them work more for the tax exemption, which Illinois has done, for example, and to really to make them kind of hold their feet to the fire, so that it's not just enough to say you have a community benefit, to do your community health needs assessment once every 3 years and call it good, but to actually sort of meet certain, to prove on certain hard metrics that you are actually benefiting your community in exchange for that tax exemption.
The nonprofit one, Rachel, as you know, there's an extensive literature on this in economics, which is very, very tricky because financially, for-profits and nonprofits don't look all that different. And many of the most profitable organizations are officially nonprofit. Doesn't mean you can't make a profit, just means you can't distribute it in certain ways. You can't do certain things with it. On the other hand, the nonprofits do tend to provide a different set of services than the for-profits. They're more likely to provide psychiatric emergency services, which is not something that your typical for-profit is going to provide the emergency part of it. They'll provide some psychiatric services, but not necessarily the emergency side of it, and other low-income services. So I think there's a sort of mixed record on it. And I do think Erin's right that the regulatory stance matters a lot, that, when you can shame a nonprofit easier than a for-profit. And so you can go to them and say, look, here you are, you're not taking any Medicaid folks, you're nonprofit, this is not acceptable. And then, you can often have an effect there. There was a nonprofit CEO who, Massachusetts was beating up on the hospital for something. And I was like, yeah, we're putting you through the grinder. He said, I love it. I said, excuse me? He said, yeah, I get to go tell my docs, like, I was beaten up by the state for us not doing this. And now I can get them to do all sorts of things that I couldn't get them to do before. Because, the docs wanted to make money and they were like, fine, let's not treat these people, let's treat other people. And now I can go to them and say, sorry, you can't do that because, like, I get yelled at every time you do that. So there's, but we could have also sort of done that with a for-profit, particularly if we had some of the sticks behind it too. So I think there's some difference, but there's probably less. I don't think of that as the first order difference. Like, I don't think pay attention to the for-profits, leave the nonprofits alone. I think about it as a market where I've got to worry about all the players.
Okay. Well, we only have a few minutes left, and so I want to ask each of you to look into your crystal ball, and I'd love to hear what you think the future of the business of healthcare looks like. And I realize it's very hard to predict the future today. It looks very different than it did 6 months ago. But if you were to look ahead 6 months or a year, what is the future of the business of healthcare? And you each have about a minute. Maybe. Who does someone want to volunteer to go first?
I'll go first, and I won't use all of my minutes. As you know, there are being certain policy decisions made on the fly over the last 5 or 6 weeks that could have a devastating impact on healthcare. We don't know exactly what it looks like and what we'll go through, but cuts to Medicaid can exacerbate already existing healthcare desert problems in rural areas and certain areas of urban states. It will change the payer mix at certain institutions and may change the population in emergency rooms.
I would agree with that. I think that we're probably headed for more corporatization and more consolidation because of the headwinds that are coming. So I think that paired with that, to the extent that there is any sort of like silver lining or thing to be hopeful about, I would say that states have actually been out front. Massachusetts passed legislation earlier this year. Other states are actively in their legislative sessions right now. Considering legislation, that the states are sort of the front line on the pushback to this trend, which I think Kwame is absolutely right, is coming. So I think that the two are my predictions in the short term, but also in sort of the medium term is I think we're headed for more corporatization, contraction of lots of resources for states, and at the same time, states really having to step up and figure out, what are they going to do, and being kind of innovative in that space.
I like being an optimist because it's more fun than being a pessimist. So that may be the only reason why. But I do think we're getting better at public policy for healthcare. So despite everything that's gone on, the growth of medical spending is much slower in the past decade than it was before that. Coverage has expanded. The quality of medical care in some areas keeps going up. And I think it's a testament to our ability as policy people to learn like what doesn't work and then try other things and find something that works and then do better there. So I'm hopeful we'll continue to do that and be able to continue to have more coverage, keep the costs affordable, and do what we need to do so that particularly learn what we need to do so that these issues, now that they've arisen, will be better able to address them.
All right. Well, I like ending on an optimistic note, so thank you. I want to thank all three of you for joining me today. It's been a really great conversation, and I appreciate you taking the time to do so. I also want to invite the audience to join us for our next seminar. It's coming up in March, later in March, Boosting Health Through Economic Policy, Tax and Labor Policies to Improve Population Health. So join us then. There was more information on our website if you're interested. Thank you guys very much for joining us today. Take care.